So today I will be talking on non-surgical management of vulvar cancer. Selection is the key. So we all know that recently we have the 2021 FIGO staging for vulvar cancers. And this is the first time that the FIGO has come up with a staging based on prospective data collection of more than 12,000 patients. And the staging of vulvar cancers, which used to be so complicated, now has been simplified. It is based on a very robust database, although mainly from multi-institutional studies. And this is basically from the National Cancer Database of the US. And this has now been, it correlates very well to the treatment outcomes. So it has been very simplified. And as in cervical cancer, the lymph node metastasis now has been incorporated into stage 3. And stage 1 is tumor confined to the vulva. Stage 2, again, does not have any subsize, and it is tumor of any size, which extends either into the lower 1/3 of urethra, or to the lower third of vagina, or to the lower third of anus with negative nodes. And once you come to stage 3 and stage 4, so this is advanced disease, which either has disease extending more proximal, or with fixity of lymph nodes, or increased in number of lymph nodes. With either more number of, with involvement of lymph nodes. And stage 4 is if the disease is fixed to the bone, there are ulcerated lymph node, or there are distant metastases. So if we see this staging corresponds very well to the survivals, and which was unlike what was there before. And if we see the treatment and disease outcome in vulvar cancer, we know that the mainstay of management of vulvar cancers is surgical resection, followed by lymph node assessment. The 5-year overall survival in limited disease is 86%, which again very well corresponds to the recent staging that is shown. Once the regional nodes are involved, the survival dropped down straight away to about 50%, and it is only 16% in metastatic disease. So the involvement of groin nodes is one of the most important prognostic factors in vulvar cancers. The 5-year local control rates are to the tune of 75%, and there is approximately a 23% risk of cancer-related death if there is a local recurrence. Now, because of this staging, we can divide the adjuvant treatment, that is a non-surgical treatment based on stage-wise distribution. So if we come to the early stage of vulvar cancers, that is stage 1 and stage 2, this is the disease that is confined to the vulva, and the mainstay of treatment in stage 1 and stage 2 disease is surgery and groin resection. So essentially here, the risk factors that are there for local recurrence are based on the classic old study based on Heaps criteria, where a positive or a close margin predisposes or is the most important factor for local recurrence. Here, a close margin is basically designated as a formalin fixed margin of less than 8 mm pathologically, or a 1 centimeter clinical margin. And this margin, if it's less than this, that disposes to a 50% chance of local recurrence. The other criteria that we creep into account, which do predispose for a local recurrence, are LVI, or lesions that are less than 5 mm deep. In addition, poorly differentiated tumors, especially those with infiltrative margins, are the ones which again have a higher chance of local recurrence. But the most important criteria remains a positive or a close margin. Now, how does a positive or a close margin affect survival? Now, it predisposes not only to local recurrence, but 5-year overall survivals are also dismal once the patient has a local recurrence, and they straight away fall to more than 80% to less than 25% if the patient has local recurrence. So what do you do once a patient has a positive or a close margin? The treatment of choice is always re-excision if it can be done, because these are early stages cancers. So as in cervical cancer, we do try and avoid a biomodality treatment. So if the patient only has a close margin or an involved margin in the absence of other risk factors, and re-excision is something that should be done. The advantage is that there is avoidance of radiation-induced toxicity, especially vaginal stenosis. And we know that vulvar surgeries itself do cause loss of body imaging and are not very welcoming for the patient. So radiation should be avoided if re-excision is possible. In addition to that, re-excision is usually difficult in midline tumors where it is difficult to obtain a large margin. So the other alternative is radiotherapy. And the outcomes with radiotherapy as compared to the re-excision are comparable. Radiotherapy is preferred in midline tumors. And radiotherapy is also preferred when there are presence of other risk factors. So you have to look at other risk factors. And if there are there, then the radiation is what should be preferred over re-excision. In addition to that, it's not only the 8 mm margins. Studies have shown that margins of less than 5 mm are also associated with higher risk of vulvar recurrences. There is also a dose-response association, and doses of more than 56 gray are associated with higher risk of local relapse as compared to 50 gray, which used to be used traditionally. So what is important now is that the margins of 5 mm have to be considered as compared to 8 mm, although this is not followed classically by most of the centers, but this is something which needs to be considered in the background of other risk factors, and the doses of radiation have to be in excess of 55 gray, especially they have to be more than 56 gray. Now coming to advanced diseases of stage 3, 4A and 4B. Now the most important prognostic factor is node positivity, and the second group is the unresectable disease. That is because of the disease extending to the nearby structures, or it is because it is difficult to obtain a negative resection margin. Now, like I said before, that lymph node is the most important prognostic factors, and there are certain aspects of lymph node involvement which we need to be careful and to keep in mind before planning adjuvant treatment. Because especially in countries like ours, the LMIC countries, we do not have standardized surgeries, and often we may predispose the patient to increased risk of recurrence by overlooking these factors. So the important aspects to be looked into in regards to the spread of vulvar cancers is that lymph nodes are pathologically assessed in patients with primary tumors that are deeper than 1 mm. So any depth of invasion more than 1 mm warrants lymph node surgery. And even in the absence of clinically negative lymph nodes, about 30 to 40% patients do have pathologically positive lymph nodes. So the groin has to be addressed, even if clinically there aren't any lymph nodes, even if radiologically the lymph nodes are negative. Now, contralateral nodes or pelvic lymph nodes are seldom involved without involvement of ipsilateral lymph nodes. And that is where there is role of ipsilateral nodal surgery, and there are indications for the same, which I will be not going into. Now, the risk of contralateral nodal involvement increases as the lesion approaches the midline. That is, we know because there is crossing over of lymphatics, and also with each additional risk factors. So this also has to be taken into account when planning the adjuvant treatment. So what are the additional risk factors? They are the tumor thickness, the LVI, the age more than 5 years, and poorly differentiated tumors that are present, that may be present, which I've already highlighted before. So these are the factors that need to be considered once you have to plan to irradiate the groin lymph nodes. Now we know that inguinofemoral lymphadenectomy or sentinel lymph node biopsy is the standard of care in patients with stage 1B or higher disease who have clinically negative lymph nodes on examination. So we know the role of SLNB, and the criteria for SLNB includes a tumor diameter of less than 4 centimeters, more than 1 mm of depth of invasion, no palpable groin nodes, and a unifocal disease as shown by the groin SS vulvar study. Now, is there a role of radiotherapy if there is involvement of sentinel lymph node? So this is a recent study published in 2021, where the role of radiotherapy versus inguinofemoral lymphadenectomy was evaluated for patients in vulvar cancer who had micrometastasis in sentinel lymph node. So the standard practice is that if a patient has metastasis in the sentinel lymph node, the patients do go in for the IFL, that is, the groin has to be addressed surgically. Now, what happens is once the groin is addressed surgically, there are increased chances of lymphedema. So hence the role of radiation was evaluated. Now, in patients who had micrometastasis of less than 2 mm, radiotherapy was shown to be comparable to involved to the lymphadenectomy in reducing the groin recurrences. So the results are comparable at the benefit of reduced toxicity with radiation compared to IFL. So in patients with micrometastasis of less than 2 mm, radiotherapy is a safe alternative to IFL in patients who have sentinel lymph node micrometastasis. However, patients who have sentinel lymph node macrometastasis, that is metastasis of more than 2 mm or extracapsular spread, the standard treatment should be addressing of groin with the surgery, that is inguinofemoral resection, followed by radiation if indicated. So can we do away with groin resection and can it be replaced by radiation in patients who are clinically negative? So this was addressed in the GOG 88, where patients were randomized to groin resection versus bilateral groin radiation. Now, what this study showed was that there was an increase in groin recurrence to the tune of 18% in the radiotherapy arm versus 0% in the surgery arm, leading to early closure of this trial. What was important was that 20%, that is 1/5 of the patients in the surgical arm, did have positive lymph nodes and went on to receive radiation. And the dose of radiation was 50 gray, which was prescribed at the depth of 3 centimeters. And I'm sure that the radiation oncologist sitting here in the audience would know that the depth of inguinal lymph nodes can be as deep as 3 to 18 centimeters. And the dose that would have actually reached the inguinal lymph nodes would have been much less. And hence that would have accounted for the increased number of failures. And 50% of the patients had a BMI of more than 28, meaning that the lymph nodes were deep-seated and perhaps there was underdosing of these inguinal lymph nodes. Subsequent to that, there have been some retrospective studies which have shown that there is no difference between inguinal radiation and lymph node dissection in terms of recurrence-free survival. However, there are no further prospective studies in this context. So this question continues to be unanswered. Now, so coming to the role of adjuvant RT in pelvic node positive disease, again, one of the earlier studies was the GOG 37, which showed us the role of radiation and showed us which was the group which required the radiation. So survival advantage was seen in groin positive disease, and especially if there was more than 1 lymph node positive and extracapsular extension. So these were the group of patients who definitely benefited from nodal radiation. Now, this more than one lymph nodal radiation continued to be, a point of controversy. And in 2006, the SEER analysis showed, they studied all these lymph nodes and the patterns of recurrences. And what they showed was that the 5-year overall survival with adjuvant radiation, if less than 12 lymph nodes were removed, there was a difference of about 20 to 22%. So if more than 12 lymph nodes were removed, there was a trend towards improved 5-year overall survival with adjuvant radiation, meaning that definitely a cutoff of about 10 to 12 lymph nodes was required. So minimum of 10 to 12 lymph nodes were required to be removed. And the effect or the benefit of radiation was across, there was no difference in the number of lymph nodes removed. So it was also, even if 1 lymph node was removed, there was a benefit of adding radiotherapy. So again, regarding number of resected lymph nodes removed, this is again another retrospective study. This was again from the NCD database, where they saw that more than 50 nodes should be removed if bilateral lymphadenectomy is done. And if unilateral lymph node dissection is done, at least 10 lymph nodes should be removed. And a negative lymphadenectomy has a negative impact, and an inadequate lymphadenectomy has a negative impact on survival, meaning that once you are evaluating the indication for radiation in terms of node positive disease, you also have to look at the number of lymph nodes that have been resected. And this also has to be done in the background of the local risk factors that are there in the specimen resected. Now, coming to the controversies in groin radiation in lymph node positive disease. Now, these were a series of retrospective studies done. What they saw was that for every positive lymph node that was involved, there was a decline in the overall survival. And for 1, 2, and more than 2 affected lymph nodes, there was a decrease in survival to 60%, 43%, and 29%. So meaning even 1 lymph node positivity did impact the survival and reduce the survival to nearly about 30%. So the most important difference actually in the survival was seen where a single positive lymph node was involved. Subsequent to this study, the AgoCare 1 study was published in 2014, which again studied the benefit of adjuvant radiation. And what they saw was that this benefit of adjuvant radiation was consistent regardless of the number of positive lymph nodes, grade, or depth of invasion. So this was an independent factor which determined the survival. And they also said that despite radiation, the outcomes were still poor. So there was something else that needed to be explored, and chemotherapy was the possible answer to the same. So again, because of the paucity of and rarity of this tumor, we know that there are few prospective studies. So most of the studies come from the NCDB analysis. So this was again a study which studied the impact of adjuvant chemotherapy with radiation for node-positive vulvar cancer. And what they saw was that there was a difference of in survival, which was highly significant once you used chemotherapy as a radiosensitizing agent. And subsequent to this, weekly cisplatin was recommended, especially in patients who had macrometastasis or extracapsular extension. And thus, a node-positive disease where macrometastasis is present and extracapsular extension is present, radiotherapy with concurrent cisplatin is now the standard of care and should be administered as far as possible. Now coming to inoperable vulvar cancers. Now these are defined where radical excision would require functional compromise or sacrifice of functionally important midline structures. So where are they indicated? They are indicated where anorectal, urethral, or bladder involvement is suspected. And this is done in an effort to avoid any extensive surgery, to avoid colostomy or urostomy, and where the disease is fixed to the bone, or where there are gross inguinal or femoral node involvement, regardless whether a bulking lymphadenectomy has been performed or not. So here comes the role of chemotherapy and RT, and chemotherapy can be given either as concurrent chemotherapy or even as neoadjuvant chemotherapy, and neoadjuvant RT can also be given in this subsetting. But subsequent to the NCDB data analysis, what is now the standard of care is either definitive chemo-RT or chemo-RT followed by surgical assessment. So this leads to an improvement in organ preservation. It reduces the surgical morbidity, and the experience largely is a borrowed experience from the radiosensitization effect that we have seen from data from anal cancers and from cervical cancers. So what is the evidence that we have for chemoradiation in vulvar cancers? So the evidence that we have basically is from small series of studies, either done retrospectively or prospectively. So the first evidence of success of chemo-RT was from the GOG 101, where a pre-operative split pros chemo-RT was seen, and a clinically CR was seen in 48% patients, and about 1/3 patients had a pathological CR. Subsequently, the GOG 25 study here, the dose escalation was done as compared to the GOG 101, and they omitted the 5FU because that leads to an increased toxicity, and they had an increased rate of pathological CR, that is the pathological CR was to the tune of 50%. Then in 2014, the NCD database, again, the data from the NCD database showed that 74% patients had received definitive chemo-RT, and the mean doses now could be escalated to about 60 gray. Patients were receiving higher doses, and this was primarily because IMRT was introduced during this period of time. And the 5-year overall survival with chemoradiation was to the tune of 50% compared to only about 28% with radiation alone. So definitely concurrent chemotherapy in the definitive form had a role to play in the management of advanced vulvar cancer. Now, the analysis in 2017, again of the NCD database, here they saw if definitive chemoradiation could be, could replace chemoradiation followed by surgery. And when they saw that once you do the dose escalation of radiation of more than 55 gray with concurrent chemotherapy, this was better in terms of morbidity and in terms of outcomes as compared to pre-op chemo-RT with surgery. And this is possible again with the use of IMRT. So dose escalation with concurrent chemotherapy in the definitive setting is definitely a better form of treating locally advanced cancers with the benefit of organ preservation and decreases and results in reduced morbidity. Now, coming to the principles of radiotherapy in vulvar cancers, the target volume is vulva, both groins and lower pelvic lymph nodes. Now, location and depth of inguinal lymph nodes is very important. And now with the cross-sectional imaging, it is easy for us to determine the depth of these lymph nodes and prescribe the doses accordingly. The position that we use is the frog-leg position to minimize the bolus effect of the skin and to make it homogeneous and to expose the areas of these folds. And bolus is something that we use to increase or to get the dose over to the skin. And this is used in cases of extracapsular extension. And it is used in cases of primary disease, especially when we use high energy beams. And for the radiation oncologists, we have to use thermoluminescence dosimeters or TLD dosimetry, basically to confirm to the dose that is delivered to the skin. Because of the anatomy, there could be a lot of inhomogeneity, and that is why we need surface dosimetry. Now, the use of midline block is controversial because studies have shown that it increases the risk of local recurrence. However, with the use of these modern techniques, it could be done away with. We could do away with a vulvar radiation in the absence of local indication for radiation for vulva. Now, the radiation techniques that are used in vulvar cancers are the conventional photon-electron technique, where we can treat the patient on a cobalt machine or a linear accelerator without using conformal techniques, where we use a photon and an electron combination. The technique preferred these days is the intensity modulated radiotherapy, and we do have evidence now from small series of evidence and now from many studies showing the advantage of IMRT, where dose escalation is possible and which is required now for vulvar cancer, which a number of studies have shown. So the minimum doses required for advanced vulvar cancer is more than 55 gray, and we take the doses now up to 66 to 70 gray with concurrent chemotherapy as well. And treatment breaks are minimized and radiation toxicities are reduced. The other technique that we use is brachytherapy. This is seldom used as an isolated technique, and this is mainly used to boost the dose to the local area after external radiation or in cases of recurrent cancers. Now, I would like to conclude by saying that adjuvant treatment is recommended when surgical margins of primary are less than 8 mm or when positive lymph nodes are identified. When treating close or positive margins, the radiation dose to the primary should be at least 56 gray or more than 55 gray. When groin nodes are involved, the involved nodal regions and the pelvic needles regions have to be treated. And this is the basic principle of radiotherapy, that we have to go one echelon above to the involved nodal areas. IMRT should be preferred. It allows dose escalation without treatment interruptions and may reduce both acute and chronic toxicities. Concurrent chemotherapy is the standard of care in advanced diseases. That is where there is gross nodal involvement, extracapsular extension, and unresectable disease. Although toxicity may be increased compared to radiation alone. So our choice and patients of patient and selection has to be carefully done. Thank you very much. Thank you, and greetings from the city, beautiful Chandigarh.